So I don't have any scientific merits in this field, but as Raphael was mentioning, I'm a practitioner, as most of you, and I have my reflections on, in the day-to-day practice on this very difficult field. And Raphael was so kind that he called this a keynote lecture. I think maybe it rises some expectations, but having seen all these nice lectures this morning, I realized that many of my points will be actually only repetition of what you've already heard. But repetition is like mother of wisdom, as we say. So I think I hope they will be complementary to all these points that already have been taken, and maybe I will show some new points. But that was really the order from Raphael, just to point things that we are still struggling with. So my agenda will be to point to some challenges in the management of pediatric TBI, to see where we have gaps in knowledge and practice, what are actually the unmet needs, and what could be the possible way to improvement. So let me start with a number. A number will be 3,000. What could that be? I mean, you've heard a lesson on epidemiology. So this is actually a number of kids still dying from TBI in Europe every year. I mean, we have between 80 and 100 million kids in Europe, approximately 20% population, and this is a number of those who die from TBI every single year. And it's probably the most civilized continents, but still we have this problem. But put it in some other number, like 200,000. It's kind of a statistical game, right? But years of life lost. So it's really dramatic. But it's what it is. I mean, we lose these people, and as we say in Norway, we don't have any children to lose. This 3,000 is just 3,000 too many. So what we can do to reduce this number? It should be our question. So we have actually a luxury in Europe that we have something called Eurostat. They have quite good data, of course, very dependent on the data delivered from national authorities. But I think we can pretty much rely on these figures. And even though the pediatric TBI are only 5% of all TBI-related deaths, it's still the second largest age group in terms of incidence of TBIs in the population. And I think it's very interesting to read from one of the studies that 1/3 of us, 1/3 of all population, will experience some kind of TBI before the age of 25 years. So it's really a societal problem. Now, just to complete this little session on epidemiology, worldwide, if you look at the age group between 5 and 14 years, road accidents is the commonest cause of death in children. I mean, it struck me, but it's how it is. And in this group, we also have a lot of TBIs, obviously, and it's 40% more than, for example, in Africa, than this triad of those infectious diseases that everyone is, really bothered by. But 40% more causes is from TBIs. Now, it's obviously a difference between Europe and America on one side, and Africa and Asia side, but you see that road accidents, injuries, and in that, of course, the TBIs were one of the leading causes of death in children, even though we know that both, the wealth of the world and as well as the mortality among children is unequally distributed in this world. So we have already heard about this. Figures from the first talk today. Force and motor vehicle collisions are the most represented. So, and I think it's funny to see that most of them happening on Fridays. I was not aware of it, but it's interesting. So I think a wonderful thing about TBIs and all injuries is actually this is not a disease. There's something that's happening, but it doesn't need to happen. So all injuries and all TBIs are in principle preventable. I think a wonderful thing about TBIs and all injuries is actually this is not a disease. There's something that's happening, but it doesn't need to happen. So all injuries and all TBIs are in principle preventable. So it's a big effort at the level of WHO and all the dedicated organizations to reduce the impact of injuries in children. Of course, we know that there is a much bigger issue in developing countries than in more civilized countries, of course. But it's really a matter of recognition, good data, will, planning, commitment, and persistence. And there was a nice example of it from Sweden for some years back. They actually managed to reduce the rate of injury in a specific population by 80% just by implementing safety measures. And it was like 20, 30 years ago. So I think we have to move further from that and really need to work on legislation, regulation, and on some kind of public marketing to get these changes done in all countries. But of course, we are very much reliant on compliance in the population. We need to cooperate with industry in terms of engineering and so on. Because, if you look on this study, for example, you see that all children that were involved in of all children that were involved in injuries as cyclists, scooter drivers, or motorbikers, half of them still didn't wear a helmet. And it's a quite recent study, but it's really striking. So at least in Scandinavia, and I'm sure in Switzerland, we all know aware if we start some kind of activity that can be dangerous to the head, we protect children. But still, if you open internet, this is one of the net shops. You see, if you want to buy something like this, it's just very funny, very fancy pictures. But it's not so fancy to see these pictures with a helmet on, from some reason. But it has something to do with education and the public marketing. So I think we still have something to working on there. So in the sports, we have learned sometimes the very hard way. I've chose hockey because I was a little bit active in that, and you see we've done some work there. I hope you appreciate the last picture is the Swiss one, and also for traffic safety measers. We also moved from having none to having some very primitive, and now today we have a little bit more advanced and based on more engineering and research. And just an example from last week, we had a little baby which was involved in a car crash, in 50 kilometers per hour, not big, but still, she suffered a fracture, she suffered a subarachnoid hemorrhage, subdural hemorrhage, had to be operated. The only reason for that was that she sat in the car seat the wrong way. Yeah, still. So that's still something to work on. The next issue we have, I think, is the logistic and the organization of care with TBIs. And that's a big issue in other continents, but also in Europe. What are the premises? And the premises are that, well, after all, at least the severe TBIs in children are not so frequent. We have already heard that small children differ from older children, children differ from adults. But the fact is, at least in Europe, that most hospitals treat both adults and children. That it creates a little bit problem with availability of expertise. But not all hospitals have pediatric neurosurgeon. Not all hospitals have pediatric intensive care expertise. And actually, numbers of pediatric TBIs treated at different centers in Europe is quite low. I was really surprised. But when we were preparing the next ENS Congress, where we have a session on pediatric TBI, I was asking several people to give a talk, and the usual answer was, well, we don't do so much pediatric trauma. I was really a big university hospitalist in several countries, so I was really wondering. If you look, let's see that, that's the problem actually across the world. The problem is not in the emergency department treatment. There's no big difference between dedicated trauma centers and non-trauma centers. The problem is the variation in the implementation of TBI management guidelines. And that's a big problem. So, to get a little bit of clue how things are, being done in different places in the world, we actually organized a little webinar 4 months ago. We invited a speaker from the United States, from South Africa, and from Europe, and we discussed these issues. And there were some very interesting points. But we still don't have a picture how the TBI management in children is performed in Europe. So we decided actually to perform a survey, which is right about to be circulated soon. So I think you all members of ANS or ESPNIC so will be contacted soon, and we will really appreciate if you can reply maybe in a little group in your hospital, because this will be very important data for the whole community. If you look like that, it's like 50 questions, and it is everything from how many pediatric intensivists do you have, what is the availability of the services, of the expertise, how many children you treat, and what are the management guidelines you use, and so on. And these guidelines are really important. You see what happened in Sweden. They performed a survey in 2006, looking how they used the guidelines, how they used an ICU in observation of these patients, and what happened after I think 15 years when they implemented the famous Scandinavian guidelines. And really they managed to increase the percentage of guidelines being used in different hospitals by almost 50%, and there was quite few patients that at the end must be observed at ICU, because we have clear guidelines. We know who is going to be observed in ICU and so on. So it also has an implication of hospital economy. The same was, there was a case at the West Coast of the United States where they investigated the effect of adherence to guidelines for the overall survival, and lastly in Australia and New Zealand. I think it was a very nice note from Andrew Reisner, who was in the webinar. He was pointing out that their experience at Atlanta, that just by implementing guidelines for severe TBIs, they actually managed to decrease the mortality by almost 15%, just by implementing guidelines. So guidelines is another issue. We have already heard today that there are actually no internationally constituted or adopted guidelines for management of pediatric TBI. I mean, guidelines that we all would agree on. But there are several guidelines, though. These are the most used one. The Scandinavian for mild and moderate head injury. And then we have guidelines for pediatric severe traumatic injury, and some Italian guidelines. And they are constituted quite differently. And there is, of course, plenty of national guidelines. But if you look at how they are constituted, it's the Italian ones, for example. It's on the level of research recommendation. So you have a lot of points when you have either strong or moderate and weak recommendation. So it's still like you can do it if you want, but be aware that there's this level of recommendation or not. It's maybe a little bit more advanced with the Brain Trust Foundation recommendation, which are probably the most used ones. But as Raphael was actually mentioning, of all these 15 topics, they actually didn't find any level 1 recommendation, and only 3 level 2 recommendations, out of which 2 are actually negative, what you should not do, you don't need to do because it doesn't work. And it was the hypothermia and immunomodulating diet. So the only level 1 recommendation which is positive is that the hypertension saline bolus can be used for intracranial hypertension, and that's what we actually know. But I found it very interesting in this report, which is quite extensive. There was a little paragraph saying that no treatment or management approach exists independent of other treatment approaches. It's a kind of ecology of all the setting. So no of these topics are complete. It's continually improving, and as I will be mentioning later, we also need to be aware of availability of resources at different places in the world. And of course, there's a problem with data collection. So a little bit more about the management of severe TBI, what we have, what we don't have. I will stress once again today, and I think it was one of the wishes from Raphael, that pediatric patients is not a little adult. There's a lot of physiological differences, and as we've always been is stress, and at least I feel it because I do a mixed practice. So when I'm treated a child, I always feel like more responsibility for the final result, because you see these parents, you see the whole family. You're thinking the child in the lifelong expectancy. So I think for the case of TBI management, we really need to know what we are doing. So and it's very nicely reflected also in this paper from intensive care people. They also stress the fact that what we're treating is the brain which is under development. It's really important difference. As compared to the adult ICU. And we also must be aware of things like post-intensive care syndrome in pediatrics, which really can be a problem even for long-time survivors. So a little bit more concrete about the things we perhaps may see as some potential for improvement. Now, this is all like monitoring or management things that we are using, but perhaps the status of autoregulation should be more pronounced in future management protocols, because I can give you an argument with this study from South Africa, which is probably the largest study so far on autoregulation in kids with severe traumatic brain injury, showing that the pressure reactivity index actually is much more strongly associated with outcome than ICP, GCS, CPP, and the age of the patient. So it's something that should be implemented in the next version of our management guidelines, I think. Intracranial pressure is my favorite topic. It is a mainstay of all guidelines for management of severe TBIs. But when we should start the ICP, it's still a matter of debate. There's a lot of inconsistency in terms of indication for ICP monitoring, and we should know that ICP is actually a very complex thing. For many of our colleagues, it's still only a number, but actually, what should the number be? I mean, we don't have any studies whatsoever in healthy persons to be able to state what is the normal ICP. Our Danish colleagues, they try to do it by putting telemetric sensors in patients operated for elective aneurysms, and they let them go for some weeks, and they taking some samples. The study has been published on very few patients, but we don't know, and even less for children. Furthermore, this number which you have on the monitor on your scope, it's only a number. You may have a nice curve, but what is this curve? Well, this curve is just a result of several factors. You're looking at the mean ICP, but then you have a zero drift, you have the shift, you have the atmospheric pressure, absolute zero pressure. So probably we should be more focused on what I call intracranial pulsatility. We have actually a possibility to retrieve from the ICP signal pulsatile parameters that are much more independent on external factors. It hasn't been done in trauma management, but I think it's one of the things that we should work on. Now, there's a lot of fancy stuff about the non-invasive estimation of ICP. And I say estimation because it probably won't be measurement of ICP from many, many reasons. And if you're interested, there's a very nice overview article from my colleagues from Oslo, on many, many sites, actually stating that right now we don't have much promising technologies coming up, to measure ICP non-invasively. So we still have to talk about estimation. I mean, in clinical practice right now, I'm sure some of you are using optic nerve sheath ultrasound, which of course, together with transcranial Doppler, it's easy to use, but the reliability and the inter-observer variability is quite difficult. So you can achieve some kind of reasonable specificity and sensitivity in terms of elevated ICP, but how good it is it's still a question. Another mention can be about the brain oxygenation monitoring. We have some good studies from adult TBI world indicating that ICP plus brain oxygenation monitoring is better as a guidance for a treatment of TBIs than ICP alone. But we don't have any studies of significance on it from kids, even though I think we should use brain oxygen monitoring because it's much better to detect these hypoxic episodes. And even it's still uncommonly used, I think that's one of the things that we should work on in the future. Another neuromonitoring stuff could be, of course, the continuous EEG. I'm sure someone of you are using that. The cerebral microdialysis was a very hot topic for like 20, 30 years ago. And my understanding now is that it's being used only in the research setting, at least at our hospital, and as far as I know, also in Scandinavia. And maybe a little hot thing is the eye tracking, which is something that could have some impact on prognostication of patients with mild TBI and concussions. Interesting study from North American ICUs showing how much they use the different monitoring in TBI patients, pediatric TBI patients. And so everyone is using ICP. Many people are using EEG continuously, but still pupillometry and brain tissue oxygenation is very little used by now. So there is a potential for improvement. We have good studies on the other side for use of hypertensiline as favored to mannitol. And there is an ongoing study in Europe on the use and timing and indication for craniectomy. Perhaps there are some Swiss centers also participating. I'm not sure, but this is the protocol has been published, and the study is quite ambitious, and I'm sure they will give us some good answers in fewer times. So, what about imaging? We've had very nice lectures today about it. I just will mention that really MRI is unequally frequently used in USA as compared to Europe. I think we are laying behind, and in our American colleagues, probably from legal reasons, so I'm not sure that they are much better to using MRI in acute setting in TBI in children, and I think we need to learn from them because really MRI has a potential to outperform CT in almost every injury-related pathologies, perhaps except of skull fractures. So why not to do it? I mean, the risk of radiation is real, as Rafael was mentioning. So this is one of the things that we really need to be better in. Well, big problem is mild TBIs. As I told you, the 1/3 of us will experience, or 1/3 of our children will experience some kind of TBI, and most probably the mild TBI, within the age of 25 years. So, and that has a consequences. There's a lot of visits to hospital, a lot of follow-up visits, a lot of symptoms that these kids have. And I was pretty shocked to see that almost 1/3 of kids having concussion also develop so-called post-concussion syndrome, which someone has called as silent pandemics, because it really has an implication of the whole society, because these people cannot live a normal life. They cannot study, they cannot work full time, and so on. So Americans, they have tried to put together some recommendations just for the management of children with mild TBIs. These are actually only recommendations. There is not much evidence for things that we probably would think are the most promising ones, like biomarkers and so on. And they stated also there is a need for age-appropriate scoring scores, and they stress the need for awareness of the variability in recovery. In Scandinavia, we are following this protocol, which is very user-friendly, but it's also very empirical protocol. It's not, if you test the things in this protocol today, I think it would probably need some kind of refurbishment. But it's coming. So right now it's a study underway. The protocol has been published. So there will be probably a new protocol in a few years' time. A big issue, of course, in the perspective of my TBIs are sport-related injuries. It has taken a time, but as per today, we finally have an assessment score, which is called a Child SCOAT 6. It's a result of a development over years. It's available now for all of us who are dealing with kids, undergoing concussions related to sports, and it's supported by big sport organizations. And it's a good result of effort of over many years. Now, when I was thinking to spend some slides on rehabilitation, because it's not only to get the patients through ICU, through emergency department, short follow-up and finished. These kids have problems afterwards. And one of my colleagues in Oslo, she actually defended her PhD just 2-3 months ago on the material from south of Norway. And even in a country like Norway, where the resources are quite good, she could state that neurorehabilitation offers healthcare for children is much less developed than for adults. And she even meant that 1/4 of patients reported unmet needs in the long run in terms of rehabilitation. And when I say unmet needs, I don't mean this. It's much more than that. And it's also been reported from larger studies from Europe. So really, rehabilitation is a very important part of the package. So a couple of slides on a very annoying thing. It has been mentioned already, and there will be talk this afternoon, as far as I know. Non-accident injury, which is also called abusive head trauma, or previously also shaken baby syndrome, which should not be used anymore. This is really a problem because it's the leading cause of death and disability in very young children. And if you compare the accidental and non-accidental injuries, so there's actually a 6-fold higher mortality rate in these children. Important to know, this is equally prevalent in developing as well as in developed countries. And I was surprised. Antoni Figaci told us in his talk 4 months ago that in South Africa, actually, abusive trauma is not so big problem because they have big families and there's not so much time left for, let's say, a father to be alone with the kid. So it's really maybe a little bit bigger problem in developed countries than in developing countries. And as they state in this article, it's really worse than you think. And the worst thing is probably that is the delayed recognition of these traumas. And I don't know how the situation is in Switzerland, but you've probably heard about the pickle in Sweden and now also in Norway. It was actually, I should say one colleague, but it was a few colleagues who went out and they question, all this triad of non-accidental trauma. They mean that some families could be actually legally injured by, being blamed for causing trauma to their children. So it's a lot of publicity around it and a lot of arguing in Scandinavian scientific literature. So I would be very interesting to hear how the situation is in Switzerland, but that's actually a discussion ongoing right now. It's not always nice because it's really it's a balance between protecting children from possible injuries caused by their own families and against families being stigmatized for something they haven't done. So it's really a big issue right now. So a few slides about research. Well, as I told you, we only have like 20% of population who are children. So, proportionally, the number of articles, number of studies will also be less than for adults. So it's very difficult to get, new hints. And speaking about biomarkers like here, because probably the most hot topic of what could replace, need for CT, MRI, for triaging the patients and so on. We still lack in evidence. So in adult management protocols, we still have included biomarkers, at least some of them. But in pediatric, we cannot do it because we don't have any evidence. And it's a problem of pediatric research in general, because most of the centers, they treat small volume of patients, but to have a clinical study or with significant results, we need big numbers. And in addition, there's a very different practice, different places. So there's a huge paradox of pediatric TBI practice or research, that most of the published studies come from high-income countries, but they are supposed to be implemented in countries where they have most injuries, and that is low and middle-income countries. And these countries, they operate it with much less resources. So this makes it really messy. So I think the answer for this problem would be to work for a global approach. It's very nice to design a study in Europe, but it probably will be applicable only in Europe. So we have to invite colleagues from other continents, cooperate with them, include them, because it really gives the answers we are trying to get. Other thing is that we are very good on holding symposiums, talk to each other and meetings, publish articles and so on. But probably we should, lift, our side outside and also speak much more to policymakers, to regulators, research funders, all these patient organizations and public in general. And really, it's not always an intuitive work for us. But everything from these simple leaflets to sometimes half stupid articles in local newspapers, but also better articles like we have now in Norway, because we see a lot of electric scooter injuries right now. So my colleagues have taken a look on it. And it has been also actually communicated to politicians. So local politicians in Oslo, they actually reduced the number of electric scooters. I think it was from 60,000 to 3,000, quite dramatically. Because we talked to them. We came to them with this article and said, well, see, we have a problem. So the next step is to convince the politicians to put the rules that you need to have a helmet when you're running electric scooter. So it's an example how things can be done. So this is a slide from Antoni Ficacci, and I would strongly agree with him. So the interventions that we are good at are these ones, of course, and we have to make all this better, of course, but maybe equally important is the social and political interventions. And I think, Shlomi, it's our responsibility. I mean, if we are office holders in big societies, we have to talk to each other. We have to prepare a good case to speak with politicians and with public. So my conclusions would be, well, there are gaps in knowledge and practice and unmet needs, definitely, in terms of everything, basically. Epidemiology, surveillance data, registries. I was surprised that not every European country has a trauma registry. And that's a problem, because we need better data. Management protocols, big problem. We have to work on it. Rehabilitation capacities and so on. But there are also solutions on the way. Let us hope that by multidisciplinary work and on management strategies that will be specifically tailored to children and continued global research, we may have better results which can be transited to clinical practice. And of course, we have to work on prevention. We have to work on what I call a public marketing. Because indeed, treatment of pediatric TBIs is a matter of very many perspectives, but they are all complementary. It's all to make effort to improve the outcomes, and we need to work together. And I think I should write the politicians and regulators there also, because it's really a part of the package. So if you're interested in this and you are attending the coming ANS meeting, we'll have actually a joint symposium with trauma section, and the program is already set. And it will follow very much of it, which I've been talking about today. So I'm sorry if I if I disappoint some of you waiting for some new findings, new hot stuff. But I think that's where we are today. Thank you very much.